Hello, I'm Fiona Ritchie.
And I'm Nik Kendrew.
We're both part of the Redwell team.
Come with us to reignite your passion for primary care.
Welcome to the Hello British Summertime Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, or your trainers, or even your gardening wear. Here's what's bubbling up as we dive in search of our pearls for this month. Here's what's bubbling up this week. Body image concerns and pursuing an increasingly muscular appearance is becoming a growing issue, particularly for men and boys. It's recently been Eating Disorder Awareness Week, and we thought we'd share a pearl about a related issue: anabolic steroid use.
Nature. So important that we should prescribe it? The short answer is yes. Spring has sprung, and to celebrate National Social Prescribing Day earlier in March, we teamed up with Intelligent Health, Natural England and the National Academy of Social Prescribing to share a video bite on the power of nature and green social prescribing in transforming patient health. Hussain Al-Zubaidi is back this month to tell us all about it.
And here's what's bubbling under for next week. Last month, ahead of the start of Ramadan, we shared our article Ramadan Supporting Patients with Long-Term Conditions as a Pearl. This month, we'd like to share with you our new video bite on the same topic. So come back next week and we'll discuss what jumped out at us from our brand new bite, Ramadan, Impact on Diabetes and Other Chronic Illnesses.
When we pick topics for our courses, we choose them because they're new or they're tricky, or something that those of us working in primary care know we need to know but won't find anywhere else. Myeloma has been a popular topic in our recent cancer and GP update courses because it is tricky. And many of us find it a bit baffling, don't we? Paraproteins, immunoglobulins, electrophoresis, light chains, monoclonal gammopathy. Gosh, it's a whole new language. But it's also tricky because it's hard to spot. Of all cancers, it has the longest interval and largest number of consultations between first presentation and diagnosis. So, to celebrate the launch of the new season of GP Update courses, we wanted to share our pearl on myeloma from last season.
And we start with our first pearl, which is anabolic steroid use. Now, as I said earlier, body image concerns and pursuing an increasingly muscular appearance is becoming a growing issue, particularly for men and boys. Eating Disorder Awareness Week was in mid-March in the UK, and we thought that we'd share a pearl about a related issue, in this case, anabolic steroid use. So I thought it'd be interesting to hear from Caroline how the original article came about.
Hi, Primary Care Pod listeners. Caroline here from the Red Whale team. I know Nik and Fiona are talking about anabolic steroids today. And these are the kinds of topics sometimes that as GPs we think, with everything else, why do I need to know about this? And at least that's what I used to think too. I wanted to share with you how the first version of this article came about nearly 10 years ago now. I still remember the day. I was duty doctor. I was seeing a temporary patient who was in his 20s who'd been dragged down by his girlfriend, and he looked really sick, agitated, sweaty, experiencing chest pain. One of those you know is going in, but you want to use your Dr. House skills to try and work out the puzzle. And I remember that his ECG showed some ST depression and left ventricular hypertrophy. His pulse was 140. And while we waited for what was a very quick ambulance in those days, what I learned was that he was a bodybuilder and he'd been taking anabolic steroids for the past 2 years, along with 12 other supplements, most of which I'd never heard of. So I realised there was a big gap in my knowledge. And that was how the first version of this article was born.
Oh, thanks, Caroline, for that. So that kind of gives us the background as to where this all came from and why the article was written in the first place. So anabolic steroids, for example, nandrolone and stanozolol, are a synthetic form of testosterone, usually taken recreationally without medical supervision in a desire to build muscle mass. Now, they're often known as roids or juice, and use is more common in men but can occur in anyone. Their use is probably more common than we realise, and the side effects can be significant. Use can also be associated with muscle dysmorphia. So as health professionals, what should we ask and what should we look out for? And how do we safely advise stopping? The written Pearl and associated article on Redwell Knowledge was updated in February 2025, and the main references are a BJGP article from 2015, another BJGP article from 2024, and a BMJ 10-minute consultation from 2016. Other references will be mentioned where relevant as we go along, and as always, full references are in the written article, and where space allows, there are links to the major articles in the show notes. Now, there is a character limit on what we can put in the show notes, as I've found to my cost on many occasions. So if it isn't there, then we've run out of characters. Now, this one took me 8 minutes and 32 seconds to read, and it took Fee 5 minutes and 24 seconds to read. So maybe not quite long enough for a bath. I put in the script there that nobody's saying that Fee skim read it. But I didn't say that, did I? Nobody said that.
Nobody's actually testing what Fee retains from this article.
So yeah, not a muscle soaking article, really. I don't think. What do you think?
No, I don't. Not even a shower, really. Maybe an environmental shower, but anyway. But yeah, a nice quick one. I was thinking maybe if you're waiting for the train or something, nice one to get in there. Cool.
So what did this one mean for you, Fee?
Oh, do you know what? I have to say, this is a total blind spot for me. I've never knowingly been involved with anabolic steroid use. And I think, well, actually, maybe it's just because I've never asked. Could just be that. It could be ignorance. And some of the points raised, the things about risks and potential irreversible damage, those were quite a shock to me. Mm-hmm. But I think if a patient did raise it with me now, I'd be a lot more informed than zero. But also I know that I can look it up really easily on Redwell Knowledge, so that's quite nice to know that, you know, there are articles there that, you know, maybe not the ones you think about every day, but give you a nice framework to work through.
Exactly. I think these kind of topics, it's just, if you know that they are there to look up on Redwell Knowledge, then that's enough, and you can just quickly, and there's always a reason why you can find an excuse to look something up, like, you know, draw the curtains and tell somebody to go and get ready and then quickly look it up if you need to. That's what I do.
Yeah.
Anyway, so this is a chance to make a big difference if we can. And the prevalence of use is hard to determine, not least because people don't often freely admit to using anabolic steroids. But according to the BJGP in 2024, it's estimated that over 1 million people in the UK are using image and performance enhancing drugs, including anabolic steroids. Global prevalence is estimated at 6.4% of males and is 19 to 53% among gym-going populations, and that's from the BJGP in 2015. So I wonder if this figure is even higher now. Now, I think it's safe to say that we probably all have at least a few on our lists. And in my experience, these consultations can be quite tricky because they're often associated with fixed health beliefs, which might be alien to us and how we practice. Throw into the mix an unhealthy dose of toxic masculinity and some social media influences, and we have a melting pot of trouble. So let's talk about adverse effects of anabolic steroids here. Now, much of the literature regarding adverse effects comes from trials where therapeutic doses were used under medical supervision. Recreational doses can be up to 1,000 times the recommended amount.
1,000 times?
Yeah, and users may use more than one steroid at the same time. So we're going to divide up the potential adverse effects into reversible, irreversible, and those where it's unclear whether they are reversible or not. So reversible adverse effects are increased appetite, scrotal pain or impotence, acne, hypertension, edema, aggression and behaviour change, and anxiety. So what about irreversible potential adverse effects, Fee?
Yeah, so these are some of the things that I was shocked by. So hirsutism, voice changes, male pattern baldness, and striae or keloid scars. And then there's tendon rupture as well, which I was thinking this is quite worrying if you're also going to the gym quite a lot, as people will be doing. But then I thought maybe that could be a good way in to maybe encourage people to stop using steroids. And then there's also cardiac disease, so thinking about ischemic heart disease and cardiomegaly, clitoral hypertrophy, short stature, especially if the steroid is taken in adolescence. And then thinking a bit more widely, thinking about bloodborne viruses from needle sharing, And an interesting one was hepatic carcinomas, which can be seen 10 to 15 years after use.
Yeah, that's quite shocking when you read that, isn't it?
Yeah.
So finally, here are those where it's unclear if they are reversible or not, and they are testicular atrophy, gynecomastia, and subfertility. Studies of users suggests that nearly 80% experience 2 or more of these side effects, but only half of them are concerned that they may lead to long-term consequences. And I had to say that in my experience, one of the most shocking things that I found about these consultations are when I've discussed the potential adverse effects that many people would go sort of pale and clammy about, I've often had responses just like a shrug of the shoulders and kind of like, I know what I'm doing, or I know the risks. And that really shocked me. And it's quite, I don't think we really get prepared for that kind of a consultation.
No, I know. And I think it's really difficult because when you kind of step back and think about this, you can think, well, are we as a medical profession failing this group of people? Whether it's about giving them support or, having the knowledge ourselves to be able to enter into these consultations. But then it also made me think, well, this is a much wider problem, isn't it? There's work that we can do, but maybe there are roles for, public health, or maybe the gyms themselves to kind of make people aware of what's going on. And it could be a combination of everything, of course.
Yeah, and I think it's an issue that's going to become more and more important. And we're now living in the age of social media and biohackers, and there are lots of people that take the ideas of influencers as the truth and ignore evidence-based medicine. And this impacts on the way that we consult. So how do we reach people who don't believe a word we're saying and who'd rather buy, often at great expense, a snake oil remedy, which at best does nothing apart from burn a hole in their pockets, and at worst, it can cause serious harm? And I guess it's about being able to help people to make informed choices by giving them all the information so they can sort of weigh up the pros and cons of these things. So this is bigger than anabolic steroid misuse, but at least some of the origins of the wider problem we see now can be traced back to the culture that has led to anabolic steroid misuse in itself. It would be fascinating if it wasn't so concerning. Now, if you've got any thoughts or ideas about this, and we'd love to hear them, how do we reach patients like this? Just send us a text by pressing the Send Us a Text button at the top of the show notes.
Yeah, and the other thing I'd like to mention here is around muscle dysmorphia and body dysmorphia, because that's also playing its part here, isn't it? And if like me, this is an area again where you think, oh gosh, just need a reminder of that, then we do have articles around those two on Redwell Knowledge. So muscle dysmorphia is now recognised as a form of body dysmorphic disorder. And so there are articles around this on Redwell Knowledge, but also around obsessive compulsive disorder. Muscle dysmorphia is characterised by usually young men becoming obsessed with muscularity and the appearance of their body. That comes from a study that was published in JAMA in 2017. And many of these men take up weightlifting and use dietary supplements. And in two, albeit very small, studies in the US, over 40% of such men were using anabolic steroids. So we need to think about these two things, kind of how they link into each other. Of course, some may choose not to use anabolic steroids, but may still unwittingly be taking them, as some of the dietary and what we would quote herbal supplements can contain anabolic steroids. So we need to ask about those too, and again, be really aware of this.
Absolutely. So what's the scale of the problem, Fee?
Well, it's estimated that in the US, around 2% of men have BDD, so body dysmorphic disorder. And of these, up to 25% have muscle dysmorphia. Young men are the commonest group affected, but the JAMA article points out that some older men who've perhaps used anabolic steroids in their youth may continue to use them, or they might restart them to try and counteract the changes of aging. So it's something to bear in mind when you see a patient using anabolic steroids, or when you see young men who may be overly concerned about their appearance or obsessed with going to the gym. And of course, don't forget to ask about supplements as well, even if they're labelled as herbal.
Yes. Now, the BJGP editorial from 2015 reminds us about another very important issue, and that it's rare for individuals using anabolic steroids to take only one drug. The written pearl has a list of other drugs commonly used, and after each of them, in brackets, is the reason bodybuilders give for use. It's important to say that because it's not the medical indications for use. Now, this was all new information to me, and there's a list that we can group together to help. So Ephedrine is what bodybuilders use to promote weight and fat loss. And then we have clenbuterol and thyroxine, which are both used by bodybuilders to burn fat. Then diuretics, which they use to get to competition weight. HCG is used by them to improve testicular function or stimulate testosterone. And then they use growth hormone and insulin, both of them to promote muscle development. And they use tamoxifen to reduce gynecomastia. And just to reiterate, those are not the medical indications for the use of those drugs, but the reasons why bodybuilders might use them. So clearly, each of these drugs comes with a range of side effects themselves, and we need to ask for the specific drug regimes of everybody that we see who is misusing anabolic steroids.
But where do we even start when thinking about issues to consider in the consultation? Thankfully, the BMJ did a 10-minute consultation on this back in 2016. What we need to remember is that individuals may present with complications, or they may be asking for advice about the safety of continued use, although unfortunately many people might just want to be reassured that they can still use them. We might have to obviously think about this in a different way. So we're going to think about how they might present to us in either of those ways. The author reminds us that we need to approach this in a sensitive, non-judgmental way. And of course, it may take a series of consultations to get to that point, as lots of behaviour change does, but also when it's around a sensitive subject around this. So it might be kind of gaining that rapport and trust before we can make any big changes. There's a great table in the written pearl which summarises what we need to do. So for all the reasons that we just mentioned, we need to take a really good drug history, don't we? Asking about specifically the substances that are used. And that might mean actually getting patients to bring those in so that we can have a look at the active ingredients. Yeah. Thinking about mode of delivery. As we've mentioned, there may be needle sharing issues, and asking about nutritional supplements. Then we also need to think more holistically, thinking about mental health, asking about eating disorders, especially bulimia, asking about body dysmorphic disorder, asking about mood and anxiety, and also thinking about domestic violence and any criminal activity.
Yeah, and that's something we should always have our antennas up for in any consultation. So thinking about physical examination, this should include BMI, also the skin, looking for acne or striae. We should also check blood pressure and do a cardiovascular system examination. And we should be looking for gynecomastia as well. And we should offer to check for testicular atrophy and an enlarged prostate as well. Now, to turn this all on its head, if you're seeing a patient about something else and the physical exam reveals things like striae or gynecomastia or testicular atrophy, then think, could this be anabolic steroid misuse? And inquire in a sensitive, non-judgmental way about it. Now, when it comes to investigations, there are lots of interesting things. So we'd recommend having a proper read of the written pearl to digest it all. The BJGP Clinical Practice Guideline from 2024 covered essential blood tests and actions in those using anabolic steroids. And we've also included in the table some pointers from the older BMJ article from 2016. Testosterone is likely to be suppressed. Now, we need to refer to secondary care if after 24 weeks off anabolic steroids, the patient remains hypergonadal. If you feel out of your depth with any of this, then I think it's more than reasonable to phone a friend at the hospital or use advice and guidance. Now, an important point to remember is that suppressed gonadotrophins with normal testosterone suggest exogenous testosterone use. Estradiol is likely to be elevated, and interestingly, a referral is not needed for this. We should advise the patient to stop using anabolic steroids. Treatment with aromatase inhibitors such as letrozole is not advised. Now, the next bit, which is all about hematocrit and polycythemia, was familiar to me because I'd read it in our testosterone deficiency in men article on Redwell Knowledge. So a full blood count is really important, and this is because polycythemia is a complication of excess steroid use. If the hematocrit is raised, so in a male it's more than 0.52 and in a female more than 0.48, then we should advise the patient to stop anabolic steroids and then repeat analysis. We should also advise about alcohol reduction and smoking cessation. If the hematocrit is very high, so that's more than 0.6 in a male and more than 0.56 in a female, then we should refer urgently to hematology. Now, I was going to say that our local polycythemia guideline doesn't mention anabolic steroids as a cause of polycythemia. However, I just went and checked it, and there it is. So it just goes to show that you can read something literally hundreds of times and you still haven't absorbed everything in it. Well, I haven't, clearly.
I think that's really interesting, though, isn't it? I wouldn't have thought of that. Obviously alcohol reduction and smoking cessation as the raised hematocrit reasons, but I wouldn't have thought for steroids. So that's a good one to know as well.
Yeah.
Obviously, we'll want to check other bloods, so USNEs, LFTs, HbA1c and lipids, of course, due to the metabolic effect of steroids, and do have a read of the article for the full list and how things can be affected. We may also want to check CK, creatine kinase and prolactin, and hepatitis and HIV screening may also be indicated if there has been a history of needle sharing or risk. I wanted to point out some interesting things though. So firstly is around EGFR. So even though we know that high muscle mass can underestimate EGFR, we should make sure that we follow local AKI or CKD pathways and refer as necessary. If LFTs are off, then we should ask about weightlifting in this group. And we need to advise no heavy weightlifting and then repeat the test in 14 days. If the ALT remains raised, then follow standard raised ALT pathway. And there's a really great article on Redwell Knowledge all about what to do to investigate abnormal LFTs. Anabolic steroids can promote a metabolic syndrome picture. So lipids and HbA1c are as important as any other part of the workup too. And with lipids, we should recheck them when the patient has stopped taking anabolic steroids. And there are some specific criteria in the written Pearl which would lead to referral. So again, I recommend that you have a read of those and follow advice regarding that. And also, I just want to turn this all on its head again, because what we're talking about here is ideally if you have someone who is taking anabolic steroids and comes in and wants to have a chat and then you examine them and investigate them. But also think, what if you have someone who presents with abnormal bloods or a raised blood pressure, especially in a young person, then actually you may need to think about anabolic steroid use here too.
Absolutely. Okay, so just to finish off then, if the patient is acutely unwell, then it goes without saying that we should refer directly to A&E for review. If there is evidence of cardiac disease that isn't acute, then we should do an ECG and we should refer for an echo because we may need cardiology input. And we may need also psychiatric support if there's coexisting mental health disorders that are present.
And management should involve discussing the risks using the information that we've been discussing earlier, which is helpfully in a table in the written Pearl. And we would also strongly encourage cessation here. And a learning point, certainly for me, is that if a person is willing to stop use, then no tapering is required. And we can advise that continuing resistance and endurance exercises will help reduce muscle loss on stopping. Thinking of the bloods, we should consider annual monitoring for these bloods. If the results remain normal over a period of years after cessation of the anabolic steroids, then we can reduce that checking in terms of frequency. But if use continues, then at least annual monitoring is recommended. And we should also signpost to other support areas and local needle exchange facilities. And we can advise that anabolic steroids are banned by sports governing bodies if that is something that may motivate someone to stop.
So here are our learning points for anabolic steroid use. It's more common than we think, with potentially serious consequences. Often more than one drug or class of drug is used.
We should encourage cessation and no tapering is required. Not all adverse effects are reversible.
We should remember coexisting mental health conditions, especially body dysmorphic disorder, and refer for help. So that's the first one in the bag. How are you doing, Fee?
Oh, Nick, I was going to say, yeah, I'm fine, but I'm not. I've got a blimmin' virus or something, one of those just annoying colds. It's not enough to make you stop, but enough to just make things a bit treacly in your brain. So I wanted to shout out to everyone who feels like me today, because
yes.
as clinicians, we all just keep going, don't we?
Yes.
And yeah, I mean, this is at least cheering me up, so that's nice.
Oh,
although I tell you what would cheer me up more.
Go on then.
Is the harp. Do you have the harp, please?
Okay, give me 2 seconds. Here it is.
Literally music to my ears. There we go. How are you, Nick?
Do you know, I'm okay, thank you. This time
Good.
last month, I was probably in a similar situation to you, and people listening could maybe have heard my voice being a bit deeper on certain bits and pieces.
Yeah.
So yeah, my voice is now back to normal. Yeah, but it's interesting what you say, that we often do keep going maybe a bit further than we should when we're sort of clinicians.
Oh,
And
I know.
sometimes for me, I just think it's a big achievement just to even get to work in the morning. So everything else is a bonus. So let's embrace that.
Oh, well done. Yeah, at least
Yes.
you're at 100% success rate then.
Totally. Yes. So there we go. So
Let's take
you-
that momentum. Yes.
yes, let's do that. Are you ready for our next pearl?
Yes, please.
Brilliant. So this one is nature so important that we should prescribe it? ? And the short answer is yes. So spring seems to be here for now, in brackets, ! And to celebrate National Social Prescribing Day, which was in March, we teamed up with Intelligent Health, Natural England and the National Academy of Social Prescribing to share a video bite on the power of nature and green social prescribing in transforming patient health. Now, in the bite, we discover how connecting with nature can improve mental well-being, physical health and social connections, and learn ways to integrate this evidence-based approach into our consultations. Now, we have a special guest again this month, but I introduced him last month. So, Fee, who is our special guest?
Well, it gives me great pleasure to welcome back Hussain Al-Zubaidi. Actually, Hussain, I've got a bone to pick with you because listeners, you may have seen on Instagram that Hussain and I were presenting a GP update course in March in Reading, which was really good fun. And the day before, Hussain suggested to me that we went for a run, which turned out to be a 10K run through farmland and all sorts of mud. And I mean, it was fun at the time, but can I just let you know that the result was my trainer's getting broken and my left little toe is now permanently bruised. So thanks for that, Hussain.
Brilliant. Well, think of the memories and the experience that we gained. We may have lost body parts and tools, but, we can replace those, right? We can replace those. No, it was a great run. Absolutely beautiful. And I think it brought to life the nature, because I didn't want to just get you to run on a treadmill in the road. I wanted us to access the nature. And for literally half of it, I think we were in the nature because our feet were stuck in about a foot of mud.
And I think actually watching that, because it struck me that it was a bit like Instagram life versus real life, because on Instagram it looked like it was brilliant fun, and then we hear the other side of it. So
yeah, to be fair, when we took the video, we were about 3K in and all was well. The ground was firm. At about 4 to 5K, we started entering essentially what was a marsh. And I didn't know any other way. So I had the only method, which was to just persevere through it, break into a farm, and then finally break over a fence to get into our hotel. So it was all good fun and games and all part of the joy of being outside.
Exactly, proper immersion. So we're here to talk about green social prescribing. So Hussain, why does nature matter?
That's a good question, Nick. Nature matters for a whole host of reasons. And I'll have to say, my realization of how much it matters has changed since we started this joint sort of project, the collaborative project with Natural England, Intelligent Health and the National Academy of Social Prescribers, as we went about to produce this bite on green social prescribing. Because in the process of doing the literature review, I realized that there's a whole host of evidence to support why it's not just, a good thing, but it can be really, really vital. And if we think about it, as little as 20 minutes in nature helps to alleviate stress and improve a number of the associated physiological biomarkers linked to stress. And a common figure that is highlighted often is for us to aim for at least 120 minutes in nature across the week. But what I thought was quite powerful was there's that positive message that even 5, 15, 20 minutes can lead to benefits. And so that can seem a lot more realistic in our modern day and age, depending on where you live and how easy it is for you to access green and blue spaces. But whether it be glycemic control, stress levels, blood pressure, we see improvements with nature. And that seems like it's a resource that I don't think we're tapping in as much as potentially we used to. And it's so important that we can think about what part we can play to support our patients.
Excellent. And just to pick up on a few things from what you were saying. So one of the things that I found really interesting is that there is evidence here, and just as little as being in nature for 5 minutes can help control blood sugar levels. And that is from Medicine and Science in Sports and Exercise from 2022. So I thought that's really interesting. And then you were talking a bit about green and blue spaces. So can you just tell us a bit about what they actually are?
So green and blue spaces are kind of what they say on the tin, but I think instead of thinking of natural spaces like that, just as, for example, the lakes or the Alps, we're talking about anything where we have natural environments. It could be our parks, it could be the garden. And what really even surprised me was Dr. William Bird said images of natural spaces can have some of the same beneficial effects, which was really surprising to me. And spending time with those colours and that atmosphere and those surroundings can lead to a whole host of different benefits on different parts of our body. And within the article, we actually have a really useful table which outlines the different categories, whether it be cellular aging, surgical recovery, sleep, vision, and how there's evidence to support that natural spaces and spending time in these natural spaces actually helps with these processes. And it doesn't surprise me, because when you read or watch any period dramas, what is the number one thing these clinicians seem to always be prescribing? It's, getting fresh air, going to the seaside, or, if you're in the aristocracy, having a trip to Italy. I think even then they could connect that spending time in these environments led to improved health. And I think it's important that we don't lose that connection that we have, and try to, show our patients that we feel that it's really important that they look to incorporate it where it's possible.
Absolutely. And I think the thing that is really important to emphasise from here is that, yes, back in the day, and as we've seen in period dramas, they have go and take the airs and all that kind of stuff. But for people that work in sort of modern medicine, it's important to say that this is very evidence-based, and we've got all the links and all the evidence is actually in the written Pearl, and it's mentioned in the Bite as well. So I thought that was fascinating to see how the evidence is very much there.
Yeah. So there was a study published in the BMJ in 2023, which I think probably is the most important thing, and given the amount of conversations that I have with patients with high blood pressure, that time spent in nature improves cardiovascular health overall, but lowers blood pressure and is associated with a lower all-cause mortality. And you think, what are the side effects of this prescription? I can't think of anything apart from maybe even other benefits, but it's such a easy way to potentially just incorporate something new to the patient, which they can likely think of as not just directly related to what they're trying to manage, let's say blood pressure, but also just a way to improve their overall well-being.
Exactly. And so just to kind of give us a kind of a more formal definition of what we're talking about. So what exactly would you define green social prescribing as?
So it's the practice of supporting a patient or a service user to engage in a nature-based intervention or activity to improve their mental and physical health. It can be as simple as signposting them to their nearest park, or it can be potentially more elaborate, where, for example, you can get ecotherapy, where there's activities within the forest. Maybe it's maintaining the forest or protecting those environments, and they can spend time actually interacting and engaging with those natural elements. But within the article, we have a really good list of kind of common examples. It could be going to your local park run and walk, which is in your nearest park. It could be a green gym, an outdoor gym. It could be some open water swimming. Or it could be some cultural or community events that are based in these natural environments. The list is really long, and I'd really recommend having a look at some of the examples of green social prescribing that we have in the article. And also think about maybe who within your team or network may be best placed to explore what opportunities there are in your area.
And then If people explore that, how do people access green social prescribing?
So it varies from place to place as to how mature and developed the green social prescribing network is in their area. Now, the vast majority of these activities are open for self-referral. So the patients can refer themselves. They can often access these activities either free or at reduced costs most of the time, in my experience. However, there may be some patients that would appreciate a supportive encouragement to attend some of these sessions, or where you feel that it may be specifically useful for them in their scenario, you may want to consider discussing it and seeing what the patient thinks about it. Now, for certain activities, you may want to engage other healthcare professionals, whether it be social prescribers, or consider what method the actual activity has in engaging new attendees. Many of them will run new groups or have a person to contact within that group, especially for those patients that may not feel as comfortable engaging in these groups and want a bit of support to access them. So, my tip would be consider and make sure that you have an understanding of what opportunities are out there and how best to access them. For patients that are highly activated, it may be a case of just signposting them to these activities for them to engage and explore. But for others where you feel they'll need more support, consider if there's any formal referral pathways or a volunteer or social prescriber that will be able to support the patient, potentially even attend on the first session to help them access these services.
I love nature. I love the garden. I love Gardener's World. And Monty, if you're listening, just give me the call and I'll come and work for you. But I do think that if we could get people to have more connection with nature, daily 20, 30 minutes out in nature, I think as a society, we'd all just feel better and be less unwell, maybe. But the thing I want to know, Hussain, is how can we make this happen in consultations and in our practices? Because Nik and I were talking earlier, and there's some amazing work going on in individual places, which I'm sure Nik will tell us about in a second. But how do we do it kind of on the ground? What are those little things that we can do? Maybe not every consultation, but to start to bring this in to our 10 or 15-minute connections.
Yeah, that's a really good question, Fiona. And I think what's really important is to appreciate we want a realistic way of utilising green social prescribing within time-pressured consultations. Now, I think what can be really important is to start off with understanding kind of what matters to you. And when I mean you, I'm talking about the patient. Trying to understand kind of what is it that they are looking for so that you can see where the green social prescribing could align with the potential expectations and use that to build your message. So, for example, many patients already, they appreciate that spending time in nature is an opportunity for relaxation and peace, or maybe simply a change of perspective. So you could potentially link that in if someone's struggling with stress or they've got a lot on their mind. You can consider asking them if they've spent time in nature or if they've gone for a walk outside to help them think and review those things in order to get a bit of clarity on their thoughts. Or it could be something where you want to be a bit more formalized. And if that's the case, as I mentioned before, understand your referral pathways. What's available locally and how's the best way to access it? And then something that I found very helpful in my area is start to build up a bit of a relationship between the practice and the social prescribing offer, including our green social prescribing, so you have an understanding of how they can best support patients. So we have in Foundry Woods in Leamington a fantastic ecotherapy group, and the leader there is just so great with new people, and she's just great for those that may be a bit more anxious, a bit more socially isolated, and she will contact the patients before they come, and that can be really reassuring for them so they don't have to turn up to these groups knowing nobody and finding it difficult doing a completely new thing. And remember, often the simplest things can have the biggest impact. And whatever our role, we can actively green our patients' behavior. Like, remember, whether it's just about adding a little bit of walking, 5-10 minutes in the day, or just adding some plants in and around the home or even our workplace to demonstrate its importance. These little things, just adding in nature here or there, they can make a difference and often can shift our perspective when it comes to nature. And sort of speaking of that, one study, in fact, that we highlighted in our article identified that as healthcare professionals, the vast majority of us, about 80%, spend a lot of time in nature. But what about our workplaces? And that made me think, because in my surgery, I couldn't actually count one plant. I did have actually one plant, but it was dead. Like, it was on my shelf near the books, and it had died a long time ago. And so it made me realise that like, we're not setting maybe potentially that the best example in our room. So I've quickly tried to resurrect that plant. Unfortunately, it hasn't worked. It's definitely dead. But I've got a new one.
And
so
what kind of a
will
plant
work.
is it? That's my question.
Oh, that is you see, I think Fiona probably would know more than me, but given her love for Gardener's World. But it's one with thin, long leaves.
Are they
that
vertical
help?
leaves? Are they vertical?
Well, maybe one day. Currently, they're all pointing downwards and are brown.
Okay, well, that's not a good look. But if you look behind, if you're listening to this, you can't see this, but Hussain can see behind me some plants in my recording studio. And those are snake plants, and they are meant to be really easy to look after, and also they're meant to purify the air as well.
Okay, see, that's what I'm going to get, because mine's not purifying anything at the moment.
So maybe get one of those. That's what I say. And yeah, as Fiona was saying, there's a practice local to me who have been doing what is green social prescribing, but even before it was called green social prescribing, they've been doing it for years and years and years. And they have this amazing garden, which has got a gardener, but it also has lots of volunteers, and people can be referred to become involved from other practices with the garden. They're encouraged to go out there and to help to tend to all the different plants and stuff. They've got vegetable patches, and attached to the garden, there's actually a cafe as well, where they make homegrown produce, and they all work together. There's volunteers, and it's the most amazing atmosphere and community, and it's just phenomenal.
Yeah, that sounds brilliant.
Yeah.
That sounds brilliant. And I think actually one of the things I enjoy most about nature is growing your own fruit and veg. I think that's the one thing. Like, when it comes to gardening, I'm not very good at growing kind of horticulture, but fruit and veg, I just love it. Because the feeling when you eat your own stuff and you're interacting with your own food, I think it's just brilliant. But I think it just shows how diverse kind of that green, that nature element can be, and whether it be them accessing some water nearby, or doing some kayaking, or even just taking a boat down the river. Like, I think we just need to broaden our horizon and give our eyes more views than just the screen. Yes. Given how much time we spend at work and in our leisure time with a screen in front of us, let's get some beautiful greens and blues and everything in between.
Yeah, and I think that one of the things that comes through from the bite, just to wrap up, is that it kind of starts with us. It's going to benefit us as well. But if we can find that passion, then that is kind of infectious, and we then help our patients to get that passion, and everybody benefit. And the other thing that's lovely from the bite and from the written pearl is that it shows so many different versions of green social prescribing, so many different activities that you can get involved in. So there's almost something for everybody, pretty much. So almost like, take your pick of what you want to get involved in, and then transfer that passion on. So it's wonderful.
A really positive story is, like, in the DEFRA report that we highlight in the article, those that gain the most from green social prescribing are those that are struggling with mental health, that have complex social needs, they may be lonely or isolated, have multiple or long-term conditions. And so kind of, these are the patients that we probably spend most of our time with, and so it's going to be most impactful for them. So I think it's really important that we consider how we can support that, because otherwise what we often see here is significant inequalities between those that have easy access to safe, affordable attractive green and blue spaces and those that may not. So we do have a potential role that we can help support our patients that may not be as aware of what's available, how they can utilise that to benefit themselves.
Great. Thank you, Hussain. So here are our take-home messages for green social prescribing. Nature helps people to maintain their well-being and their mental resilience, but many of us have lost contact with it due to factors such as urbanisation.
There is evidence to demonstrate the physiological changes that happen when we spend time in natural spaces.
Green social prescribing can be accessed directly by the patient, but for those with greater barriers to accessing it, consider prescribing it or engaging our social prescribers too. Okay, so I believe you've got the Red Whale calendar there, Fee. Is that right?
I do. But Nick, I believe there's some new music for this. So can I have the cool music, please?
You certainly can. So, drum roll, please.
Thank you. Okay, so of course it's brand new GP update time, and Kate and Catherine were in the studio last week, and Mike and Susan are out on the road holding the face-to-face courses in London and Manchester. We've got upcoming dates on the website, so do have a look at those. And we've also got cancer update courses in London. They're happening in a few weeks with Steve, David and Jackie. And Hussain is in Hartlepool and Stockton doing a GP update course there. We've also got respiratory and frailty deep dives, and that's with Sue, and that's for the East Lancashire nurses. And a men's health update webinar for IO for the Manchester group. We've also got the child and adolescent mental health course with Lee after Easter, so do have a look at that if that's something of interest. So Nick, we've got our new trainee package, which has been really popular, hasn't it? Could you tell us a bit more about it, please?
Yes, so the GP Trainee Essential Support Package. Now, this is exclusively available to GPST MDU members and affiliates. So if you're one of those, then it's free and it's worth £165, and it's designed to build your knowledge and confidence and help you pass your exams. And so what's included, I hear you ask? Well, it's really helpful because it's got Red Whale Knowledge Access, which is over 900 written resources to support you during consultations and also with your CPD. And also the Top AKT Topics Digital Handbook, which covers areas that trainees struggle with most, and webinars throughout the training year to support you with your exam preparation. So if you click on the link, then you can sign up for that.
And perhaps if you're not a trainee, but you know a trainee, then you might be able to recommend it to them.
Yeah.
So just for the terms and conditions, the package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. Our GP Trainee Essentials package is a free benefit of affiliate and GPST MDU membership.
And we just got time for some primary care superheroes.
And our first nomination is from Alistair, and it's for Dr. Stratford at Heaton Moor, who is a very nice supervisor, really helpful, and very importantly, buys coffee and lots of yummy food.
Fabulous. And then George has nominated Dr. Griffith from Healed Green Practice. They say that they're always very supportive and happy to answer any questions anytime, and they're great with patients. So thank you for those. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. And how do you become a member, I hear you ask? Well, if you're listening to us, then you're part of our pod and there's no escape. So welcome aboard. Now, all you have to do is go to redwhale.co.uk. You put Red Whale Knowledge in your basket. Don't sneak anything else in, and you enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product, so don't try it on anything else. And please also note that this voucher is all one word and all lowercase, RedWhalePod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds, and we'd really appreciate it. And if you can spare a little more time, then please give us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got value from listening to the podcast today, then please don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcasting platform.
And you can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want to see something about the podcast, then please use the hashtag RedwellPod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message, just like Caroline did, telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nik Kendrew.
Remember to keep Redwell knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Bye!